Bismillahirrahmanirrahim. So this is a study about the relationship between ATG and the development of PTLD, and not only the development of PTLD, but its subtypes also. Okay. PTLD is one of the most serious, and it is a potentially fatal complication that occurs after transplant, and it is mainly related to immunosuppression. There are 4 subtypes of PTLD according to the WHO classification in 2008. There are the early hyperplastic lesions, and these do not show signs of malignant transformation. We have the polymorphic PTLD, and this does not demonstrate, and this does not meet all the criteria for one of the B cell or the T cell lymphomas. We have the monomorphic PTLD, okay, and this the monomorphic PTLD, and this is meets all the criteria for one of the B cell and the T cell lymphomas too. Okay, and then we have the Hodgkin's lymphoma with the classic Reed-Sternberg cells. This classification was modified again in 2016, and instead of 4 subtypes, they became 6 subtypes with more subtypes in the early hyperplastic lesions. Okay, so as regards the relationship between the induction immunosuppression and ATG, literature supports that there is a relationship between the induction immunosuppressive therapy, especially the rapid anti-thymocyte globulin. It has been reported to increase the risk of PTLD in both solid organ transplant recipients and in stem cell transplants too. Okay, there were some proposed mechanisms in literature like disrupting the cancer immune surveillance and immunological control of oncogenic viruses. On the other hand, there are several other studies that fail to demonstrate a relationship between the ATG and the development of PTLD. However, these studies had either relatively short recruitment periods, or they involved transplants that were done a long time ago with different immunosuppression protocols at this time. Okay, and so far still a clear link between the rapid anti-thymocyte globulin and different subtypes of the PTLD remains scarce in literature. Okay, so the cornerstone of initial management of PTLD is the reduction or the withdrawal of immunosuppression therapy, which sometimes reverses the lymphoproliferative process. For patients with PTLD that express CD20, rituximab can be used. It can be used in combination with or followed by chemotherapy or alone with regimens like the CHOP chemotherapy. The polymorphic PTLD is usually patients with polymorphic PTLD. Usually they are less likely to need chemotherapy, okay, than patients with monomorphic PTLD and Hodgkin's lymphoma. So the aim of our study is to explore the relationship between the RATG and the development of PTLD and its subtypes, the monomorphic PTLD and Hodgkin lymphoma in renal transplant recipients. And to our knowledge, this is the first study to utilize the UNIS database aiming to explore this association. So our patients were the patients that were diagnosed with PTLD after renal transplant in the UNIS database from January 2003 until June 2017. And they received either rapid ATG or interleukin-2 receptor antagonist induction therapies, and they were discharged on calcineurin inhibitor maintenance therapy. We retrospectively reviewed them. So our exclusion criteria for the transplants were transplants other than the kidneys, multiple organ transplants, missing date or date before January 2003. We excluded the patients who received T-cell depleting agents other than ATG, historical induction therapies like OKT3, more than one induction therapy. We excluded patients who had missing data about induction therapy and patients who received treatment for acute rejection episodes, and patients who received rituximab or mTOR inhibitors at the time of discharge, and patients with the type of PTLD unknown. So the data that we collected were the recipient and donor age, sex, ethnicity, donor type, the type of induction therapy, maintenance immunosuppression medications, type of PTLD, the PRA, cold ischemia time, HLA mismatches, Epstein-Barr virus status, the cytomegalovirus, HPV, HCV, and AIDS. Okay. So actually in the 1980s and the 1990s, OKT3 and high doses of rapid ATG induction therapies were used in the USA. Afterwards, OKT3 has been commercially unavailable and lower doses of rapid ATG have been widely used. And this is the reason that we excluded the patients before January 2003 to avoid the potential use of OKT3 or higher doses of ATG. And since both monomorphic PTLD and Hodgkin lymphoma are more likely to be severe so that they need chemotherapy, both types have been combined into one group for classification and analytical purposes in our study. Even we found in literature that some authors consider Hodgkin lymphoma to be a subtype of monomorphic PTLD. However, this does not go with the classical WHO classification, but we found it in literature also. And as RATG and interleukin-2 receptor antagonist induction therapies are the two most common used agents for induction therapy, we compared both of them. We compared the RATG and the basiliximab while assessing the effect on the development of monomorphic PTLD and Hodgkin lymphoma. So we found 82,838 renal transplant recipients. 1119 of them developed PTLD, which is 1.35%. The types of PTLD will be shown in the next figure. The average time for diagnosing PTLD was more than 5 years. The incidence of diagnosing PTLD 1 year post-transplant was 0.28%. So these are the types of the PTLD. The most common is the monomorphic PTLD, which is more than 36%, followed by polymorphic, and then we can see that both the Hodgkin's lymphoma and the early lesions are small in amount, and we have about 37% the type is unknown. Okay, the others were those who had unknown type of PTLD. So after applying the inclusion and exclusion criteria, the sample size of the study was equal to 15,078 patients. 8430 patients received RATG induction therapy and 6648 patients received basiliximab induction therapy. So we did multiple logistic regression analysis assessing the impact of the induction therapy on the development of PTLD. And we found that compared to interleukin-2 receptor antagonist induction therapy, the rapid ATG is associated with increased risk of development of PTLD, with an odds ratio of 1.48, the confidence interval ranging from 1.04 to 2.1, with a statistically significant p-value of less than 0.03. Okay. This is the table. We can see that the only other statistically significant variable was the Epstein-Barr virus positivity. We also did multiple regression analysis assessing the impact of the rapid ATG induction therapy on the development of monomorphic PTLD and Hodgkin lymphoma. And again, we found that RATG is associated with increased risk of development of the monomorphic PTLD and Hodgkin lymphoma with an odds ratio this time of 1.82 and a confidence interval ranging from 1.001 to 3.33 with a p-value of 0.049. And in this table, this was the only significant, statistically significant variable was the ATG induction therapy. So the strong points in our study are analyzing the association between the rapid ATG to different subtypes of PTLD, okay, which is not common in literature, and including a huge cohort of PTLD affected renal transplant recipients abstracted from the UNIS database. And we also had a long recruitment period of 15 years. Okay, but the limitations that faced us in this study is that we used a large database with a lot of missing data and presence of non-measured confounders. And so our final conclusion is that rapid anti-thymocyte globulin induction therapy compared to interleukin-2 receptor antagonists is associated with a higher induction risk of PTLD, and not only PTLD in general, but also its subtypes, the monomorphic PTLD and Hodgkin lymphoma. And so we think that using interleukin-2 receptor antagonist induction therapy for kidney transplant recipients with low immunologic risk may be a better option to avoid a higher risk of PTLD and its different subtypes. Okay, thank you.